Hello, all, and thanks for joining us again for another great conversation in our Reducing Venous Depletion podcast series. Joining me today is Vygon's National Clinical Educator, Connie Girgenti, Megan Hansen, and Christina Fellner. Megan and Tina are vascular access nurses on the Pediatric Vascular Access Team at the University of Maryland Children's Hospital. Welcome to all, and thank you for joining us. I am now going to turn it over to Connie so she can ask Megan and Tina some questions about their journey to reducing venous depletion for their patients.
Thanks, Steve. And hello and welcome, ladies. As a pediatric nurse, it's always a pleasure to talk to passionate nurses that are striving to make a difference in our patient population. First, I want to congratulate you for being early adapters for the EPIV. It's not always easy to be early adapters, is it?
No, it's not.
No, definitely. As nurses on the Pediatric Vascular Access Team, I understand a goal of yours was to reduce pokes for your patients. Can you tell us just a little bit about that?
Sure. We specifically have a lot of, we have a big cardiac surgery population in our hospital unit. So we see a lot of babies from day one of life, up until they're a year old that require multiple surgeries, and they really need stable vascular access beyond that immediate post-op period. So we found we were asked to insert a lot of PICC lines in these patients, just to have stable access, to give, regular IV meds. And we really thought that, that was unnecessary in some of these patients, and we wanted to see what other options were out there. So we were really happy to find, a nice small extended dwell PIV that we could insert in these patients in, a variety of locations. And we found that once we started using this product, we were getting dwell times anywhere from, 5 days up into a month. And it really saved these patients multiple IV insertions, multiple attempts at labs, and we felt really preserved the veins in these babies that we know are going to need multiple surgeries and multiple attempts at IV access. So it was a really nice bridge, and ultimately reduced their eclampsia risk of not having to have a central line that we didn't really need for a central purpose.
I think with these cardiac babies as well, their anatomy is not normal, their vasculature is often not normal as well. And in an effort to reduce these sticks, like we had talked about, PICCs were not appropriate, temporary CVLs were not appropriate. And at the time, our physicians were saying, well, just place a PIV. But I think everyone knows those obviously do not last, especially in these smaller babies. Whether it be through medications or just flushing intermittently, we were blowing through them frequently. So every day these kids were getting another PIV, and you're running out of your easy go-to locations to put in that just in case line like Tina had talked about. So the extended dwells really did bridge that gap for us, so we could just put this in so that way everyone was happy. They didn't have a central line, or we could get out their temporary CVL sooner, but we also weren't blowing through small peripheral veins on a daily basis.
Yeah, and kind of once we used the line in these patients initially, we saw that it really fit the needs of multiple other patient types in the PICU. So we had patients that were intubated for respiratory distress. We were able to place these EPIVs in these patients and save them sometimes temporary central lines when all they needed was, just a really stable IV for sedation while they were intubated. They weren't requiring central medications or long-term antibiotics, and we could get these kids through, their hospital course with just these extended dwell peripheral devices, and saving them attempts at central lines, multiple attempts at peripheral lines. We had this nice line to bridge the gap.
Yeah, that's great. And a lot of these patients are definitely chronic, so it's not a one-time hospital visit. So saving those veins really are important. And like I said, as a pediatric nurse myself, it's it was nothing more heartbreaking than just poking and then having a parent sit and watch too. So it's trifold. So that's really awesome. And then when you talk about saving veins, did some of your patients also have a central line, and this was just an additional peripheral? Because I know obviously the goal is to reduce central lines, but sometimes they have one, but it's just not enough access.
I think it's both in our case. for many of the cardiac patients, they're striving to pull out these central lines that were placed in the OR. We even recently had a baby who had an RA line that really wasn't necessary, but people were hesitant to remove it until we had that, what we call stable IV access, and people know that the extended dwell is more stable, in which was what we've shown than just a traditional regular peripheral IV. We do have other patients that have a lot of incompatible medications and may have a double lumen central line, and they are unstable, but we still need a stable line for some of these intermittent medications that are safe to run peripherally. So we will place leader flexes in those patients as well.
Wow, that's awesome. Ken, you guys recently did a project and presented at AVA, and it was entitled From Tall to Small, One Size Doesn't Fit All. Can you just expand on that a little bit?
Sure. So what we did was, what we presented was that, when you're working in a pediatric setting, your patients can be anywhere from 0 days of life up until 21 years of age. Right. They can range in size from a couple kilos up into the hundreds of kilos. And how do we, as pediatric clinicians, equip ourselves with the proper tools? So we looked at, various extended dwell devices and, took a look at our data to see, are these devices able to complete therapy for these patients' IV needs, when they can have a peripheral line instead of a central line. So we looked at the leader flex. We also looked at some larger extended dwell IVs, and our data was really exciting. It showed that a lot of these lines were completing therapy, or we were getting dwell times, up into the, like I said before, 5 days to, up into a month. So our data did show that they do serve a purpose and help us fill our pediatric toolbox, and that there is no one-size-fits-all option. But when you can have reliable devices that can, fit different sizes and, multiple sizes of devices, you really are acting in the best interest of your patient and really helping to preserve their veins.
A couple things we did learn from this project was buy-in is very important, I think, as everyone knows, from not just physicians, but also bedside nurses and family members. And it did take some time to get buy-in from people. And you really, I think in this field, have to prove what you're doing is the right thing for patients, because nurses and providers haven't seen things like this before, or haven't maybe had great successes. So being able to prove, look, they're easy, look, we have greater first 6 success with these, they're lasting through to completion. Several were able to be discharged to home. That was something new for us. Several went to rehabilitation centers. So it was a lot of education with home care companies and rehab facilities about what the device is, how to change it, just things to be mindful of. But all in all, I'd say it was very successful. And now, we have people asking for them all the time because they have bought in, see the value, see the worth in the device.
And they see that it can last. You talk about buy-in. That was one of the things I wanted to ask you, was that, it's not always easy, and there's definitely struggles getting new products in and implementing change and the education. You talk about patients going home. That was more education. So, obviously there were some obstacles, but in the end, I think that, you're seeing the benefits. But what were some of the obstacles outside of, buy-in? I think that's always my biggest one, is getting people to trust what I'm saying and, give something a good try.
I think as we grow as a vascular access team in general, we have greater buy-in from physicians and LIPs. I think when we initially started, people would say, well, it's still a PIV, I still want that PICC line. We don't want anything but the PICC line. So really trying to show in the data and what's published to say, no, look, this isn't the appropriate device. To have that back us up in what you said, proving that you are a trusted source and that, yes, you do have the right answer for this patient, and that a central line is not appropriate, and we do need to be thinking outside the box for them. But I think as our relationships grow with a lot of subspecialties at our institution, we now have services contacting us saying, hey, we have this kid, they're going to be MPO a couple days. We know they've been challenging. Can you place an extended dwell on them? Or we have to get started with whatever medication. And this patient's also scheduled for a procedure. Can you come to the OR while they're sedated and be placing extended dwells in these patients? And I mean, our numbers have just grown based on the buy-in from these people, seeing how successful we've been with their patients.
Yeah, and also the ease of insertion helps that whole process. We, as pediatric, specialists, we engage child life specialists. We involve the family. We involve the bedside nurse in our insertions. And when you have that holistic care team there, and they can see, our skill level, they are well supported. They get through the procedure. It's often our data in our projected show that we are nearing first stick success with every patient. We really are inserting these lines efficiently. Once you see that process, then bedside nurses, when they have the next patient, they think, oh, maybe this kid would benefit. They'll contact us. They'll help be our eyes out there and say, I think this patient needs it, or clinicians will see it, or family members will ask, or even child life specialists will say, oh, this kid might need an EPIV because I saw you do one on this one, and they're kind of like a similar situation. So that also helps just kind of spread the word and get like a good buzz out there that, once you see it in action and that it is effective, really helps.
Absolutely. Yeah, that's amazing, you guys. Seriously, you just gave me goosebumps. When you talk about, that they're requesting you, and then I think outside of pediatrics, the adult patient or the adult nurses, they don't really understand like all that goes into a peripheral for a PD patient, right? It's like you said, it's child life, it's the parent, it's the bed. Like you are really performing under pressure, right? There's so many eyes on you. And to be able to do this in one stick and being called by so many disciplines really is commendable. Amazing work for sure. So you've talked a little bit about being called in every different direction. So obviously the impact is beyond maybe the PEDS ICU or the initial unit you started in. Is it branching in? Are you on the floor? Have you gone? I think Steve had mentioned something about the NICU. So is it becoming bigger than you thought it was going to be?
Absolutely. So we primarily started in the PICU and our PEDS progressive care unit, just based on patient need and population and what is compatible with this device. And we have seen it branch into placing them in a infusion center where patients had challenging access and were going to be admitted for a different therapy, and they've been placed there. I don't know that we've placed any I haven't done any in ED. Have you?
I've done one in the ED on a patient that I knew would be admitted.
We've done the Heme clinic before, and now, branching into the NICU. We had a 4-hour class for NICU PIC inserters that are also bedside nurses on how to insert this catheter, and have developed a sign-off process to get them comfortable with it. In the interim, while everyone is not signed off yet, they are contacting us, and their physicians are contacting us saying, hey, we heard about this. Do you think you can come assess the patient? We actually presented at one of their faculty meetings just to give them a little bit more knowledge about it, and really provide some education, which, is always ongoing, as every unit, has their own struggle. So we're really branching off into the NICU more and more, and are getting calls a couple times a week to at least evaluate patients for extended dwells over there.
Oh wow, that's just awesome. I think I want to come hang out with you guys for a couple days.
Anytime.
That would just be awesome. Is there a patient that really stands out to you, that just really made you think to yourself, okay, all of these struggles, all of these efforts are worth it. I'm doing the right thing.
Yeah, so we had a patient maybe about a year ago who was a NICU graduate, had been home for a brief period of time, trach vent dependent, G-tube, chronic illnesses, who unfortunately, I believe, was suffering from respiratory illness at the time and had to escalate some ventilator settings. And in an effort to do that, really needed to be sedated and to get the antibiotics into this child in order to treat them so that she could go back home. Tina and I were consulted for an IV, and then, we read the chart, talk to the team, and determine, I don't think a peripheral IV is appropriate for this patient, and advocated to put an extended dwell in them. Team agreed, contact Child Life, we get everyone on board. We decide to give the patient a little extra sedation so that way she's nice and calm for the procedure. And then in talking with the mom, we have great communication with families. Mom had verbalized that historically she's a challenging child to poke, and that her vessels are better in her legs. So we did a very, very thorough job of assessing every vein before we stuck and found one. Was it her popliteal or her saphenous?
Yeah, I think it was like a saphenous that was very superficial on the back of her calf.
And Mom said she loves tummy time. Well, we proned her and got her comfortable, and were able to place it successfully. And it was the only catheter she had her entire hospitalization. She received all of her sedation. She completed her course of IV antibiotics. She got IV diuretics to dry out her lungs further. And the mom was so impressed with everything. She had asked Child Life, wow, are those two sisters? They just work so well together. The flow was wonderful. And she was just so impressed with how quick and easy it was. And, we always let families stay in the room for a procedure so, they can watch what's going on and be there to comfort their child as well. And we had great success. I think she was almost 2 weeks, maybe she was here.
Yeah.
It was wonderful.
Wow, with one IV.
That's
when you think about it too, how many, like if you would have put in a peripheral, like how many pokes she might have been experienced to. I think for me, my biggest, journey in all of this is, we never maybe you counted like for an attempt, it took 5 attempts to get an IV, right? And that stuck out in your mind. But then you don't count the next days and then the next days. And when you talk about a patient like her, like she really could have been stuck far too many times, right? Like it's just, it's unbelievable, how many times we do sometimes stick patients and we don't know what we don't know, right? We're not counting. So.
And I think as the vascular access team, find ourselves feeling responsible for getting that data and having a nurse call and say, oh, we've already stuck my kid X number of times. And then us really playing that role of saying, okay, is this appropriate for the patient? Do they actually need this line? Or is this line the best for them? Could we be doing something else? And being the ones to hear that data, report it up, and try and make the best decision as a team to advocate for that patient to do the right thing.
Absolutely. Oh, that's amazing, you guys. Just amazing. I think, is there any one particular thing that you would like the listeners to take away from this little podcast? I don't know, words of wisdom. If there's somebody who's going to do it, just something you might want them to keep in mind, or just anything that you'd like to share?
Well, I would say, it's challenging. It's challenging to get new products into a hospital. It's challenging to get buy-in. It's challenging, to have to learn a new skill and constantly improve upon it. But, it's not easy. If it were easy, everybody would do it. But you just kind of have to have confidence that you're doing the right thing for your patient. And as long as you're following that mantra and you really believe in it, then, the things will fall into place. You can overcome hurdles. You just have to push hard enough.
Yeah,
absolutely. And I think advocating for your patient and having your bedside nurses see that escalation, I think, has really empowered a lot of our nurses to do the right thing and say, hey, stop, this isn't the right thing to do for this child. And I think that's amazing to watch grow here.
Absolutely. It really is amazing. You guys have done a wonderful job for your patients. And, I just want to say, a very true, sincere thank you for taking the time and sharing how you're actually making a difference to reduce the number of times patients are getting poked. I know first and foremost, they appreciate it. And of course the parents do. And keep up the amazing work. And I'm looking forward to hearing other things that you guys are accomplishing as a team, as sisters.
Thank you, Connie.
Thanks.
Wow, guys. Seriously, what an amazing conversation. I have to say, I remember when you guys began your journey a couple of years ago, and to see and hear where you are today is really just amazing. The impact that you've had on your unit, across the University of Maryland medical system, and most importantly, your patients and their families is truly a remarkable thing. You should be very proud of what you've done, and you really do deserve a huge congratulations. Personally, I also feel very fortunate that I've been able to be a part of this journey, and want to thank you for letting me be a part of it. So thank you very much for that. As we wrap up, again, Connie and I just want to thank Megan and Tina again for spending some time with us today and for sharing their experiences on how they reduced venous depletion for their patients. I also want to thank all of you for joining us today on this podcast, and want to make sure that you join us for our next podcast in our Reducing Venous Depletion series, which should be out soon. You'll be able to find it by following us on Twitter, on LinkedIn, at VygonUSA.com, as well as ReducingVenousDepletion.com. Thank you again to everyone, and have a great day.